Your body has a defense system. Immune cells patrolling every tissue, ready to fight infection, ready to protect. But sometimes that system flips. The alarm bells never stop ringing. White blood cells attack your own organs. Cytokinins flood your bloodstream like a broken dam. Blood vessels leak, organs fail, death creeps in within hours. These are not allergies. These are wars your body wages against itself. 7 types of immune reaction that can kill you faster than most cancers. 7 ways your protector becomes your executioner. Which one sits closest to you right now? Your skin starts itching. Throat tightens. You cannot breathe. Within 15 minutes, you're on the floor, heart racing, then stopping, blood pressure dropping to nothing, anaphylaxis, the immune system's nuclear option, mast cells everywhere exploding at once, histamine flooding tissues, blood vessels opening so wide, your blood pressure vanishes, airways squeezing shut. 1 peanut, 1 bee sting, 1 wrong antibiotic, that is all it takes. The reaction happens in 2 phases. First exposure teaches your immune system to hate something harmless. Your body makes immunoglobulin E antibodies. They sit on mast cells waiting. Second exposure triggers the avalanche. Those antibodies recognize the invader. Mast cells degranulate. Thousands of inflammatory chemicals dump into tissue. Histamine, tryptase, platelet activating factor. Your throat swells, skin erupts in hives, gut cramps, heart rhythm breaks, brain starves for oxygen. The numbers tell the story cold. Anaphylaxis kills between 2 and 5% of people who experience it. Approximately 1 in 50 people will have anaphylaxis in their lifetime. In the United States alone, emergency departments see over 200,000 cases every year. Food causes 40% of severe reactions. Peanuts lead the count, then shellfish, then tree nuts. Medications trigger 30%. Penicillin and related antibiotics top that list. Insect stings account for 20%. The rest remains mystery. Idiopathic anaphylaxis. No known trigger, just your immune system deciding today is the day. Epinephrine is the only drug that stops the cascade. You have minutes, maybe 10, maybe 5. Without treatment, the mortality rate climbs to 1% for food-related cases, higher for drug reactions, even higher for venom. The speed matters. Reactions that start within 5 minutes kill more often than those that take 30. Biphasic reactions hit twice. First wave settles. You think you survived, then 4 to 12 hours later it comes back. Happens in 20% of cases. Second wave can be worse. If you value documented immunology and emergency medicine history like this, subscribe. It is the best way to support our work. Also, comment from which city you are hearing this from. Also, this script is researched and factual, using sources from the Journal of Allergy and Clinical Immunology, published August 2017. A precision medicine review on anaphylaxis diagnosis that breaks down phenotypes and endotypes at the molecular level. We pulled additional data from mechanisms governing anaphylaxis published in the International Journal of Molecular Sciences in July 2021, which maps the cellular pathways from mast cell to organ failure. These are not generic medical websites. These are peer-reviewed immunology journals tracking every mediator, every receptor, every pathway that turns protection into destruction. Now back to the information. The pathways branch. Not all anaphylaxis follows the same route. Type 1 reactions run through immunoglobulin EI, the classic path. But researchers identified 3 other mechanisms in the past decade. Type 1 immunoglobulin. G reactions happen during chemotherapy infusions. Monoclonal antibodies like rituximab trigger it. Immune complexes form. They activate different receptors. Symptoms look identical. Same hives, same shock, same mortality risk, but tryptase levels stay normal because mast cells are not the main players. Neutrophils and macrophages drive this version. Cytokine release reactions present differently. Chills first, then fever. Blood pressure drops later. Interleukin 6, tumor necrosis factor, alpha, interleukin 1, beta flood the system. Happens with chemotherapy agents like oxaliplatin. The treatment matters here. Epinephrine helps less. Corticosteroids work better. Tocilizumab blocks interleukin 6 directly. Mixed reactions combine both paths. You get mast cell mediators and cytokine storms together. The worst of both mechanisms. Complement-mediated anaphylaxis triggers through a separate system entirely. Radiocontrast dye, dialysis membranes, polyethylene glycol in some vaccines. The complement cascade activates directly. No antibodies needed. C3AI, C4AA. C5 of flood tissue. These anaphylatoxins bind mast cell receptors. Same symptoms. Different cause. Blood transfusions should save lives. Sometimes they end them. Acute hemolytic transfusion reaction. The wrong blood type enters your veins. Your antibodies recognize foreign antigens on red blood cells. Anti-A antibodies meeting type A blood, anti-B meeting type B. The reaction starts within minutes. Red blood cells explode. Hemoglobin spills into plasma. Free hemoglobin is poison. It clogs kidney tubules. Acute renal failure follows. Disseminated intravascular coagulation starts. Your clotting system activates everywhere at once. Small clots form in capillaries. You bleed and clot simultaneously. Organs starve. The complement system goes wild. C3b coats red cells. Macrophages in your spleen and liver devour them. More hemolysis. More free hemoglobin. The feedback loop accelerates. Fever spikes. Back pain hits. Dark urine flows. That is hemoglobin passing through kidneys. Then blood pressure crashes. The reaction happens in 1 out of every 38,000 to 70,000 transfusions. Sounds rare until you count total transfusions. Millions per year in the United States alone. The mortality rate sits at 2%. Clerical errors cause most cases. Wrong patient, wrong blood bag, misidentified sample at collection. Nurses transposing numbers, doctors not checking labels, human mistakes killing people. The worst reactions happen fast. ABO incompatibility triggers intravascular hemolysis. Red cells burst inside blood vessels. Extravascular hemolysis is slower. Happens in the spleen. Antibodies against KID, Duffy, Kell antigens cause this. The volume matters. Transfuse 200 milliliters of incompatible blood, and mortality jumps. But fatal reactions happen with as little as 25 milliliters in children. The immune response intensity depends on antibody titer. Higher levels mean faster destruction, more complement activation, worse outcomes. Switzerland tracks this closely. In 2020, they reported 1 hemolytic reaction per 10,000 transfusions. 22 severe cases. The United States FDA collected data over 32 years. From 1976 to 2007, ABO mismatches killed more people than you would expect. They ranked in the top 3 causes of transfusion-related death. Alongside transfusion-related acute lung injury and bacterial contamination, treatment is supportive. Stop the transfusion immediately. Push fluids to protect kidneys, diuretics to maintain urine output, dialysis if kidneys fail. The damage happens fast, but the consequences last. Delayed reactions occur days to weeks later. Your immune system was exposed to foreign antigen years ago. Antibody levels dropped below detection. Pre-transfusion testing missed them. New red cells enter. Antibodies rise again. Secondary immune response within 3 to 7 days. The transfused cells get destroyed. Less dramatic than acute reactions. But in critically ill patients, this tips the balance toward death. Your skin was fine yesterday. Today it burns. Blisters form on your palms. Red patches spread across your torso. The rash looks like target lesions. Bull's eyes on your chest and back. Mucous membranes bleed. Mouth ulcers make eating impossible. Eyes burn. Genitals blister. This is Stevens-Johnson syndrome. Or, if more than 30% of your skin detaches, toxic epidermal necrolysis. Both are the same disease, different severity. Both are medication reactions. Both can kill you. The mechanism is brutal. CD8 positive T cells attack your skin. Cytotoxic lymphocytes recognize drug molecules presented on keratinocyte surfaces. Human leukocyte antigen proteins display the drug like a warning sign. T cells read it as danger. They release granulysin, perforin, granzyme B. These molecules punch holes in skin cells. Keratinocytes die by apoptosis, then necroptosis. Then they just detach. The epidermis separates from dermis. Sheets of skin slough off. You look like a severe burn victim. But this is immune-mediated, not thermal injury. The triggering drugs have patterns. Allopurinol leads the list. Used for gout. Anticonvulsants follow. Lamotrigine, carbamazepine, phenytoin. Combining lamotrigine with valproate multiplies risk. Sulfonamide antibiotics cause it. So does trimethoprim, sulfamethoxazole. Nonsteroidal anti-inflammatory drugs in older patients. The timeline is consistent. Symptoms start 1 to 3 weeks after first exposure. Faster if you took the drug before. Fever comes first, then the rash, then mucosal involvement, eyes, mouth, genitals, respiratory tract. The diagnostic criteria use body surface area. Less than 10% detachment equals Stevens-Johnson syndrome. 10 to 30% equals overlap syndrome. More than 30% equals toxic epidermal necrolysis. The numbers determine mortality. Stevens-Johnson syndrome kills between 4.8 and 9% of patients. Overlap syndrome. Mortality ranges from 19.4 to 29%. Toxic epidermal necrolysis has the worst prognosis, 14.8 to 48% mortality depending on the study. A grading system called Scorton predicts death risk. It uses 7 variables: age over 40, heart rate over 120, cancer or blood malignancy present, body surface area involved over 10%, blood urea nitrogen above 10 millimoles per liter, serum bicarbonate below 20 millimoles per liter, blood glucose over 14 millimoles per liter. Each factor adds 1 point. Score 0 to 1 means 3.2% mortality. Score 2 means 12.1%. Score 3 jumps to 35.3%. Score 4 reaches 58.3%. Score 5 or higher exceeds 90% mortality. The treatment debate continues. No consensus exists. Some centers use intravenous immunoglobulin at doses above 2 grams per kilogram. The theory is that immunoglobulin contains anti-Fas antibodies that block the death receptor pathway. Studies show mixed results. 7 out of 9 large case series found benefit, 2 found none. Cyclosporine works for Stevens-Johnson syndrome specifically. It blocks T-cell activation. Corticosteroids remain controversial. Some centers use them. Others avoid them, fearing infection risk. Supportive care matters most. Transfer to burn unit. Fluid resuscitation, temperature control, wound care, infection prevention, nutrition support. The acute phase lasts weeks. Survivors face long-term complications, ocular damage in 70%, scarring, dry eyes, blindness in severe cases, skin pigmentation changes, genital scarring, vaginal or penile adhesions, lung damage, bronchiolitis, obliterans, psychological trauma, and the risk of reacting again if exposed to the same drug class. Cross-reactivity between related medications is real. Take lamotrigine once and react. You might react to other anticonvulsants. The drug must be avoided forever. If you value documented pharmacology and dermatology research like this, subscribe. It is the best way to support our work. Also comment from which city you're hearing this from. Also, this script is researched and factual, using sources from the Journal of Investigative Dermatology, published March 2016, which analyzed morbidity and mortality across the United States, using the nationwide inpatient sample from 2009 to 2012. We also used Frontiers in Medicine, published August 2022. A systematic review of 1,059 PubMed case reports spanning 40 years that breaks down severity, demographics, and outcomes across the disease spectrum. These are not dermatology blogs. These are epidemiological studies with tens of thousands of patient records, tracking every variable from culprit drug to discharge status. Now back to the information. You receive stem cells from a donor. Bone marrow transplant to cure your leukemia. The graft takes, new immune cells populate your body. Then 30 days later, your skin erupts in rash, diarrhea starts, 10 bowel movements per day, liver enzymes climb, bilirubin rises. Your eyes turn yellow. This is graft versus host disease. The donor T cells recognize your tissues as foreign. They mount an attack. Your body becomes the battlefield. Acute graft versus host disease strikes within 100 days of transplant. Chronic form appears later, sometimes years later. Both involve the same core problem. Donor immune cells reject the host. The opposite of transplant rejection, where host rejects graft. This is graft rejecting host. The conditioning regimen sets the stage, chemotherapy and radiation damage tissues before transplant. Damaged cells release danger signals. Inflammatory cytokines, damage-associated molecular patterns. These signals activate antigen-presenting cells. Dendritic cells in recipient tissues pick up host antigens. They present these antigens to donor T cells. The donor T cells see foreign human leukocyte antigen molecules. They activate, they proliferate. They differentiate into effector cells. CD8 positive cytotoxic T lymphocytes attack tissues directly. CD4 positive helper T cells coordinate the assault. They release interferon gamma, tumor necrosis factor alpha, interleukin 2. The cytokine storm damages skin, gut, and liver primarily. The incidence varies by transplant type. Matched sibling donor carries lowest risk. 30 to 40% develop acute graft versus host disease. Unrelated donor pushes risk to 50 to 70%. Mismatched transplants approach 80 to 90%. The grading system uses organ involvement. Skin stage 0 means no rash. Stage 1 covers less than 25% body surface. Stage 2 covers 25 to 50%. Stage 3 covers more than 50%. Stage 4 adds blistering and desquamation. Gut staging uses stool output. Stage 1 equals 500 to 1,000 milliliters diarrhea per day. Stage 2 equals 1,000 to 1,500. Stage 3 exceeds 1,500. Stage 4 means severe pain or bleeding. Liver staging follows bilirubin levels. Stage 1 equals 2 to 3 milligrams per deciliter. Stage 2 equals 3 to 6. Stage 3 equals 6 to 15. Stage 4 exceeds 15. These organ stages combine into overall grade. Grade 1 means stage 1 to 2, skin only. Grade 2 adds stage 1, gut or liver involvement. Grade 3 means stage 2 to 3 gut or liver. Grade 4 means stage 4 of any organ. The mortality tracks with grade. Grade 1 has good prognosis. Grade 2 shows moderate risk. Grade 3 reaches high risk. Grade 4 patients have poor outcomes. Studies show 1-year overall mortality of 35.2% in acute graft versus host disease patients. At 100 days post-diagnosis, non-relapse mortality hits 25.5%. Half of all patients die during follow-up. The timeline compresses for severe disease. Patients with grade 3 or 4 disease face 80% mortality at median 80 days. Chronic graft versus host disease affects 50% of long-term survivors. It damages skin, mouth, liver, lungs, joints, and eyes. The clinical picture resembles autoimmune disease, scleroderma-like skin changes, Zika syndrome with dry eyes and mouth, bronchiolitis, obliterans in lungs. The pathophysiology differs from acute disease. B cells play a larger role. Autoantibodies develop. Fibrosis replaces inflammation. Treatment for acute disease starts with corticosteroids. Methylprednisolone at 2 milligrams per kilogram per day. Response rate ranges from 35 to 60%. The other 40 to 65% becomes steroid refractory. Second-line options include calcineurin inhibitors, tacrolimus, cyclosporin, mycophenolate, mofetil, sirolimus, extracorporeal photopheresis, ruxolitinib. The mortality in steroid refractory disease exceeds 70%. Among patients who progress despite treatment, 82% die at median 116 days. Lower gastrointestinal involvement carries worst prognosis, 85% mortality at median 74 days. The long-term outlook remains grim. Patients who survive severe acute disease have worse quality of life 5 years later, higher rates of medical comorbidities, lower physical function scores, 19.2% 5-year non-relapse mortality even after surviving the first year. Compare that to 10.6% in patients who never had severe disease. Your blood is poisoned. Bacteria multiplied in your lungs. Now endotoxin circulates everywhere. Your immune system detects the invasion. Macrophages activate. They release tumor necrosis factor alpha, interleukin 1, interleukin 6. The cytokine cascade begins. Other immune cells join in. Neutrophils, lymphocytes, endothelial cells, everyone secreting inflammatory mediators. The goal is to fight infection. The result is friendly fire. Blood vessels become leaky. Fluid shifts from bloodstream to tissues. Blood pressure drops. Your heart pumps faster, trying to compensate. But there is not enough fluid to pump. Tissues starve for oxygen. Lactic acid accumulates. Organs begin to fail. This is septic shock, the extreme end of sepsis. The third international consensus definitions, published in 2016, made the criteria clear. Sepsis equals infection plus organ dysfunction. Organ dysfunction means sequential organ failure assessment score increasing by 2 points or more. Septic shock equals sepsis plus hypotension, requiring vasopressors to maintain mean arterial pressure above 65 millimeters of mercury plus lactate above 2 millimoles per liter, despite adequate fluid resuscitation. The combination carries hospital mortality exceeding 40%. The immune dysregulation happens in phases. Early phase shows hyperinflammation, cytokine storm, interleukin 6 levels climb above 1,000 picograms per milliliter. Interleukin 8 follows, interleukin 10 joins in, tumor necrosis factor alpha floods tissue. This pro-inflammatory response damages everything. Neutrophils release proteolytic enzymes, reactive oxygen species. Neutrophil extracellular traps that catch bacteria but also damage blood vessels. The endothelium activates, adhesion molecules increase, leakage accelerates. The coagulation system joins the fight, tissue factor expression rises. Thrombin generation increases, microthrombi form in capillaries. Disseminated intravascular coagulation develops. You bleed and clot at the same time. Then immunosuppression follows. Lymphocytes die. Apoptosis triggered by overwhelming inflammation. T cell counts plummet. CD for positive helper. T cells vanish. The survivors become anergic, cannot respond to new infections. B cells fail to make antibodies. The patient becomes immunocompromised by their own immune response. Secondary infections follow: hospital-acquired pneumonia, catheter-related bloodstream infections, viral reactivations, cytomegalovirus, herpes simplex. The vicious cycle continues. The numbers are staggering. Global Burden of Disease Study analyzed data from 1990 to 2017. 48.9 million sepsis cases worldwide per year. 11 million deaths. That represents 19.7% of all global deaths. Sepsis kills 1 in 5 people who die. The mortality depends on severity. Sepsis without shock shows 15 to 25% hospital mortality. Septic shock jumps to 30 to 50%. Some studies report even higher. One analysis of 243 septic shock patients found mortality rates between 25 and 30% for sepsis and up to 50% for septic shock. Another study tracking patients over time found 51% died within 2 years of sepsis diagnosis. Old age predicts death. So does cancer history. Dementia increases risk by 90%. The acute phase mortality is just the beginning. Survivors face post-sepsis syndrome, cognitive deficits, physical disabilities, frequent rehospitalization, chronic inflammation persists. The immune system never fully recovers. They remain vulnerable to new infections. Quality of life plummets. Many never return to baseline function. The treatment has evolved, but gaps remain. Early antibiotics, within 1 hour of recognition, reduce mortality. Fluid resuscitation with 30 milliliters per kilogram in first 3 hours. Vasopressors for persistent hypotension, norepinephrine, first line, source control matters, drain abscesses, remove infected devices, debride necrotic tissue. Beyond supportive care, immunomodulation remains experimental. Trials of tumor necrosis factor inhibitors failed. Interleukin-1 antagonists failed. Most anti-inflammatory approaches failed. The reason is timing. By the time you suppress inflammation, immunosuppression already started. Some patients might benefit from immune stimulation. Others need immune suppression. We cannot yet tell which patient needs which approach. The heterogeneity of sepsis makes targeted therapy nearly impossible. Gram-positive bacteria cause different responses than gram-negative. Fungal sepsis differs from both. Viral sepsis is its own entity. The host response varies by age, genetics, comorbidities, and infection site. One-size treatment cannot fit all. You cannot stop shaking. Fever spikes to 40 degrees Celsius. Your liver and spleen are massive, palpable below your ribs. Blood tests show pancytopenia. Red cells, white cells, and platelets all dropping. Ferritin level exceeds 10,000 micrograms per liter. Triglycerides above 500. Fibrinogen below 150. Bone marrow biopsy shows macrophages eating blood cells. Hemophagocytosis. This is hemophagocytic lymphohistiocytosis, a syndrome of immune system overdrive. Natural killer cells and cytotoxic T lymphocytes fail to regulate themselves. They proliferate uncontrollably. They activate macrophages. The macrophages engulf red blood cells, white blood cells, and platelets. Your bone marrow becomes a graveyard. The activated immune cells release cytokines in massive quantities. Interferon gamma dominates. Tumor necrosis factor, alpha joins. Interleukin 1, 6, 10, and 18 flood the system. The cytokine storm causes the clinical picture: fever from interleukin 1, liver damage from tumor necrosis factor, bone marrow suppression from interferon gamma. Organ dysfunction spreads. 2 forms exist. Primary hemophagocytic lymphohistiocytosis results from genetic mutations. Perforin gene mutations in subtype 2, UNC13, D mutations in subtype 3, STX11 in subtype 4, STXBP2 in subtype 5. Each gene disrupts cytotoxic lymphocyte function. The cells cannot kill effectively, cannot clear infected cells, cannot turn off after activation. This leads to uncontrolled proliferation. Primary disease usually presents in infancy. Median age 3 to 6 months. Without treatment, median survival is 2 to 6 months. Even with chemotherapy, symptoms recur. Hematopoietic stem cell transplant is the only cure. 5-year survival after transplant reaches 66% in children. Secondary hemophagocytic lymphohistiocytosis occurs in people with previously normal immune systems. Triggers include infection. Epstein-Barr virus leads the list. Cytomegalovirus. Herpes viruses, influenza, HIV, bacterial sepsis can trigger it. Malignancy triggers it. Lymphoma especially. Leukemia, solid tumors less commonly. Autoimmune disease triggers it. Systemic lupus, erythematosus. Still disease, rheumatoid arthritis. The underlying condition activates the immune system. The activation spirals out of control. Hemophagocytosis follows. The diagnostic criteria come from 2004, called HLH 2004. 8 criteria exist. You need 5 out of 8 for diagnosis, or molecular diagnosis of a known genetic cause. The criteria include fever lasting 7 days or more, splenomegaly, cytopenia affecting 2 or more cell lines, hypertriglyceridemia or hypofibrinogenemia, hemophagocytosis and bone marrow, spleen, or lymph nodes, low or absent natural killer cell activity, ferritin above 500 micrograms per liter, soluble CD25 above 2400 units per milliliter. The H-score offers probability estimate. It uses 9 variables, including immunosuppression status, temperature, organomegaly, cytopenia count, ferritin level, triglycerides, transaminases, fibrinogen, and hemophagocytosis on biopsy. Score below 90 gives less than 1% probability. Score above 241 exceeds 99%. The cutoff around 169 has 93% sensitivity and 86% specificity. The mortality is brutal. Overall mortality rate reaches 41% in adults. 1-month mortality sits at 27.7%. 1-year survival, only 50%. In pediatric patients, 11.3% die within 7 days of admission. 28.8% die within 30 days. Risk factors for early death include sepsis, myocardial damage, shock, respiratory failure, coagulopathy, gastrointestinal disorder, and multiple organ dysfunction syndrome. Malignancy-associated hemophagocytic lymphohistiocytosis has worst prognosis. Median survival only 2.8 months compared to 10.7 months for non-malignancy cases. Treatment follows HLH 94 or HLH 2004 protocols. Etoposide is cornerstone. It kills activated T cells and macrophages. Dexamethasone suppresses inflammation. Cyclosporine blocks T cell activation. The regimen lasts 8 weeks for induction, then maintenance until transplant. For patients who respond on warrant, hematopoietic stem cell transplant follows. This cures primary disease. Secondary disease may resolve if the trigger is eliminated. Treat the infection. Treat the cancer. Treat the autoimmune flare. Some patients achieve remission without transplant, but relapse risk remains high. Novel therapies target specific cytokines. Emapalumab blocks interferon gamma. FDA approved it for primary hemophagocytic lymphohistiocytosis in 2018. Tocilizumab targets interleukin-6. Anakinra blocks interleukin-1. Ruxolitinib inhibits JAK-STAT pathway. These agents show promise in refractory cases, but mortality remains unacceptably high. The disease progresses fast. Diagnosis often comes late. By the time treatment starts, multi-organ failure is already present. The window for effective intervention is narrow. A vaccine saves your life from rabies. 2 weeks later, you develop fever. Joint pain in your hands and knees. A rash spreads across your trunk. Swollen lymph nodes appear. You feel miserable. This is serum sickness, an immune complex disease. You received heterologous antibodies, proteins from horses or rabbits. Your immune system recognized them as foreign. It made antibodies against them. Those antibodies bound to the foreign proteins. Immune complexes formed, small enough to stay in circulation, big enough to cause problems. The complexes deposit in blood vessel walls, in joint spaces, in kidney glomeruli. They activate complement. C3a and C5 DERWA act as chemoattractants. Neutrophils arrive. They try to clear the complexes. In doing so, they release enzymes, elastase, myeloperoxidase, reactive oxygen species. The surrounding tissue gets caught in crossfire. Vasculitis develops. The blood vessel walls inflame, become leaky. Symptoms emerge as immune complexes clear, usually 7 to 14 days after exposure, faster if you were exposed before. The antibody response is already primed. Symptoms can appear within days. The classic triad includes fever, rash, and joint pain. The rash is urticarial or maculopapular, sometimes vasculitic with purpura. It often starts at injection site if the antigen was injected, then spreads. Arthralgias affect hands, feet, ankles, knees, shoulders. True arthritis with joint swelling occurs less commonly. Less frequent features include lymphadenopathy, splenomegaly, glomerulonephritis with blood or protein in urine, peripheral neuropathy in rare cases. Guillain-Barré syndrome has been reported. Vasculitis can affect any organ, heart, lungs, brain. These severe complications are uncommon. The disease is usually self-limited. Symptoms peak around day 10 to 14, then gradually resolve over several weeks. Complete recovery is the norm. Laboratory findings support diagnosis, decreased complement levels, C3 and C4 drop, total hemolytic complement decreases, immune complexes circulate, erythrocyte sedimentation rate rises, C-reactive protein elevates, skin biopsy shows leukocytoclastic vasculitis, immune complex deposits visible with immunofluorescence. The complexes contain immunoglobulin G, immunoglobulin M, immunoglobulin A, and complement components. The causes have shifted over time. Early 1900s saw serum sickness after diphtheria antitoxin, tetanus antitoxin. These were horse-derived anti-sera. Widespread use meant widespread serum sickness. Modern medicine still uses heterologous proteins, antivenom for snake bites, scorpion antivenom, spider antivenom, rabies immune globulin, antithymocyte globulin for transplant rejection. These are made in horses or rabbits. Serum sickness risk persists. Medications can cause serum sickness-like reactions. The mechanism differs slightly. No true immune complexes form, but clinical picture is identical. Antibiotics cause most cases. Cefaclor in children, trimethoprim, sulfamethoxazole, penicillins, cephalosporins, ciprofloxacin, monoclonal antibodies trigger it. Rituximab causes serum sickness in autoimmune disease patients more than cancer patients. 54% of rituximab-induced cases occurred after first dose. 78% were treating autoimmune disease, particularly systemic lupus erythematosus. The theory involves B-cell lysis releasing intracellular antigens. These bind to existing autoantibodies. Immune complex formation accelerates. Vaccines rarely cause it. No routinely recommended vaccines in the United States have shown serum sickness risk as of 2012, but older vaccines derived from animal tissues did. Treatment focuses on symptom relief, discontinue the offending agent if possible. Nonsteroidal anti-inflammatory drugs for joint pain, antihistamines for rash, corticosteroids for severe cases, high-dose intravenous methylprednisolone for 3 days, then oral prednisone taper. Plasma exchange removes immune complexes in refractory cases. Rarely needed. Most patients improve within days of stopping the trigger. Symptoms fully resolve within weeks. The prognosis is excellent. Death is exceptionally rare. Occurs only when vital organs are involved. Severe glomerulonephritis causing renal failure, vasculitis affecting heart causing myocarditis, neuritis causing Guillain-Barré syndrome with respiratory failure. These complications are the exception, not the rule. The danger lies in re-exposure. Using the same antiserum or medication again risks accelerated reaction, more severe symptoms, shorter time to onset, even anaphylaxis. Patients must be informed. Avoid the trigger forever. Medical records must document the reaction. Alternative treatments must be used. If no alternative exists, consider desensitization protocols. Gradual increasing doses under close monitoring. This works for some medications, not for all. The immune system does 2 jobs: recognize self, attack non-self. The boundary seems clear. Your proteins are self, everything else is non-self. But the line blurs in medicine. We inject foreign proteins to prevent disease, antibodies from other humans, from animals. We transfuse blood cells with different surface markers. We transplant organs with different human leukocyte antigens. We give drugs that bind proteins and change their shape. Each intervention asks the immune system to tolerate something foreign. Sometimes it complies. Sometimes it declares war. The 7 reactions we covered represent the war scenarios. Anaphylaxis, hemolytic transfusion reaction, Stevens-Johnson syndrome and toxic epidermal necrolysis, graft versus host disease, septic shock, hemophagocytic lymphohistiocytosis, serum sickness. Each has unique triggers. Different timelines, distinct mechanisms, but they share core features: excessive immune activation, cytokine release, tissue damage, organ failure, high mortality without rapid treatment. Some are predictable. Others strike without warning. None discriminate by age or health status. The paradox cuts deep. Medicine created most of these reactions. Antibiotics enable Stevens-Johnson syndrome. Blood transfusions enable hemolytic reactions. Stem cell transplants enable graft versus host disease. Antisera enable serum sickness. Our attempts to heal created new ways to die. We accept the trade because the alternative is worse. Bacterial infections killed millions before antibiotics. Leukemia killed every child before bone marrow transplants. Rabies killed everyone before antiserum. The therapies we use today carry risk, but they carry less risk than disease itself. The calculation shifts patient by patient. For someone with strep throat, the risk of Stevens-Johnson syndrome from antibiotics is tiny, 1 in 10,000. The risk of untreated strep is higher. Rheumatic fever, kidney damage, Sepsis? The antibiotic makes sense. For someone getting matched sibling stem cell transplant for acute leukemia, the risk of graft versus host disease is 50%. The risk of leukemia recurrence without transplant is 90%. The transplant makes sense. The equation balances differently each time. If the future holds promise and peril, precision medicine might prevent some reactions, genetic testing before prescribing drugs, human leukocyte antigen typing before stem cell transplant, detailed antibody screening before transfusion. We can identify people at risk. Sometimes we can choose alternatives. Sometimes no alternatives exist. Then we proceed with caution. Close monitoring. Rapid intervention if reaction starts. The drugs improve. Newer antibiotics with lower Stevens-Johnson syndrome risk. Better immunosuppression protocols reducing graft versus host disease. Targeted therapies blocking specific cytokines in sepsis. Monoclonal antibodies replacing horse serum for antivenom. Each advancement chips away at the problem, but new treatments bring new risks. Immunotherapy for cancer causes immune-related adverse events. Checkpoint inhibitors release T cells to attack tumors. They also attack normal tissue. Colitis, hepatitis, pneumonitis, endocrinopathies. The pattern repeats. Power to heal, power to harm. The immune system does not compromise. A mass grave sits near the White Sea. The deaths occurred in 1 year. Laboratory investigations reveal multiple graves across northern Europe. Each contains bones with peculiar periosteal reactions. Inflammation markers still present after centuries. The pattern matches descriptions in ancient texts. Immune system overreaction to disease. The numbers stack up. 14 bodies in one pit, 23 in another, 41 in a third. Death clusters, consistent timing. Young adults predominantly. These were not battle casualties. These were medical events, probably infections that triggered immune cascade, sepsis before we understood it, cytokine storm before we named it. The archaeological record proves one truth. Immune reactions killed our ancestors. They still kill us now. The mechanisms we understand, the mediators we can measure, the outcomes we can sometimes prevent. But the fundamental biology remains unchanged. Your immune system can save you. It can also destroy you. The difference between those outcomes narrows to minutes, to one correct decision, to the right drug at the right moment. That is where you stand when your body turns against itself. Between function and failure, between survival and death, with nothing but time, knowledge, and luck to separate the two.